Hey folks, my name is Emily and I'm the community manager here on 2 Diabetes, working with Diabetes Hands Foundation. And today we are joined by Gary Scheiner, CDE extraordinaire and person who does and knows everything diabetes. Gary is a community favorite here and he joins me for a live interview every other month so that we can check in with him again and learn more about what he has been doing. He is the human guinea pig, tries a lot of new gadgets and things on himself. And today we want to talk about hitting the holiday season with diabetes. It's going to be our focus, but of course the topics can range all over the place. So for those of you who are watching right now and are logged into 2 Diabetes, I apologize, our chat room is down at the moment and we're working on it. And hopefully it will be up again so that you can post your questions as we're talking to Gary. Gary, welcome. The camera's on you. Please start off by introducing yourself and telling us a bit about your amazing accomplishments.
Well, Emily, you did so much already, and you forgot to say that I'm a legend in my own mind. That's a key part of your persona.
I'd like to leave that to you to say.
There you go. All right. Well, I'm just humble me, Gary Scheiner. I'm a diabetes educator. Been in practice for about 25 years. Had type 1 diabetes for 30 years. How long have you had it?
I have had it for 37 years.
You got me.
I won.
You're a better dancer than me, and you got diabetes longer. All right. I was diabetes educator of the year a year ago, which was kind of neat. I got to tour around, do a lot of presenting. Written a bunch of books. Think Like a Pancreas is mine, and just wrote one called Practical CGM to help people get better function out of their continuous monitors and learn more from them. I just got the Dexcom G5. I've been playing around with this for about a month or so. It's pretty nice. I mean, my favorite thing is I just don't have a receiver to lose. I used to misplace my Dexcom receiver all the time. You've done that, haven't you?
It's you know what? It's a gadget that's almost like begging to be misplaced.
Yeah.
It's so easy to miss, and it's small and it's kind of slippery. I know so many people who have left it in taxi cabs or it falls out of your pocket.
Mm-hmm.
I have to say I have actually never misplaced it because I'm super careful to always keep it in my purse.
You got me.
Where I am, I have my purse and my Dexcom is in it.
I need a purse. I need a purse. See, I misplaced it so many times. I would actually pay my kids to find it. They would scour the house. They knew the usual places. They'd look in the seats of the car, under the bed, places like that. And I mentioned that at a conference at the Children with Diabetes meeting, and all the parents in the room were like, uh-huh. One woman said, "You do realize your kids are hiding it, don't you?"
Oh my God, she's smart and she knows your kids.
She knows kids, yeah. I don't know if they were or not, but they don't have that opportunity anymore because it's on my phone.
Wait, but we have to talk about that. But first, I have kind of a funny story because when you're around a lot of people who have diabetes, who all have sort of some of the same diabetes gadgetry, you can mix up whose is whose. And I actually once had an experience where I was hanging out with my colleague, Mike Lawson, and we were sitting at a table together, and we had actually each taken out our Dexcom receivers and put them on the table. And then I got up, I walked away, I came back, and I was like, oh my God, I can't find, I guess I did misplace my receiver once. I can't find it, I don't know where it is, help me look for it. And we're looking everywhere for my receiver, and then Mike checks his pockets, and it turns out he had one receiver in each pocket. So then we're like, to figure out which one is which, we're like, well, who's got the blood sugar of 300 and who has the blood sugar of 200?
What I thought you were going to tell me is that you accidentally took Mike's and he took yours and you were dosing off each other's blood sugars.
That would have been disastrous.
That could be dangerous. Insulet had a problem like that with the Omnipod, the remote control, the PDM for it. When the first versions came out, there wasn't really any identification on these things. So now they put people's names on the home screen and you have to confirm that it's yours every time you wake it up. Because kids would go to a camp and there were multiple kids using them. They'd mix them up and can't tell them apart, and they would start dosing each other at a distance.
Oh my goodness. Yeah, I use a Dexcom, an Omnipod as well, and I've heard people complain a little bit about that screen, that every time you want to use it, you have to confirm, like, yes, my name is Emily. But I get why that's really important.
It's funny, mine doesn't say my name is Emily. Oh, that's why it's mine.
Yours is faulty.
Got it.
So back to the G5.
Yeah.
More about the G5 and your experience with it.
Well, it's overwhelmingly been positive. You know, I really like having the data right there on my phone. The trend graphs show up very clearly. All you have to do is press one button on your phone, your 3-hour screen shows up. You turn sideways and you get your 24-hour or 12 or 6. And if you scroll your finger across, you get your individual data points. And if you've entered event markers, they show up right on this screen. Unlike, you know, the old receiver, they didn't show up at all. So they show up right on here so you can see what happens. So that part's kind of...
So when you say event markers, you mean things like exercise, food, stress?
Insulin, yeah. Another thing that's kind of neat is you can customize the alerts on here. So for example, if I wanted to, I could make my low alert sound like this. If I wanted to. My kids are grown up. I heard enough of that for years and years and years. But so you got like 22 different options for the kind of...
And what does your low alert actually sound like? What did you set it as?
Oh, I've got it on vibrate. I don't like it to make any noise. But for those who want the noise, you have that option. So
you know, that's actually, I think that's actually interesting, because I feel like as a person who wears a lot of different gadgets that beep and buzz and bing and make these noises, I've developed a little bit of a, like, I hear a beep just out in the world and I'm like, ah, my machines.
Now, there are medications for that, Emily.
Yeah, I'm on them, Gary.
Maybe more of these medications?
I need more. But you develop this reaction to beeping sounds if you're someone who wears gadgets that warn you about stuff using beeps. So this is interesting. You could tell it to warn you some other way, and maybe that would short circuit that sort of twitching reaction that some of us have. Yeah,
you know, a distinctive type of a ringtone. I think it's a good idea. I guess just a way of personalizing it a little bit more, which is nice. So we're not just a number. And I mean, it's not a perfect system. There's some things about the G5 that I would have preferred they did a little differently. You know, for example, it'll show you the last 24 hours on screen. There's no reason it couldn't scroll back to previous days. They didn't bother to include that. They didn't fix the issue of the repeated low alarms. So if you're hovering around your threshold within a few points, every time it goes above and then back below, it alarms again. They could have fixed something like that. And something I didn't really think about until I saw someone else do this, but when I want to check my blood sugar, I have to look at my phone, which is fine if I'm by myself, but if I'm with somebody and I'm constantly looking at my phone,
that's kind of rude.
Like, Emily, hey, how you doing?
Right.
It looks like I'm ignoring you. It looks like I'm being rude. So I have to explain to everybody, I'm not just checking messages. I'm checking my blood sugar here. So don't feel offended.
I'm texting someone more interesting than you while I'm talking with you.
Yeah. The transmitter is different only in that it sends a Bluetooth signal. The transmitter is a little bit thicker. It sticks off the skin slightly more than the G4 transmitter did. And its life is only 3 months. And it's not like the other one where they had a 6-month life, but it really lasted a year. This really only lasts 3 months. It has a shut off after 3 months. So every 3 months, you got to replace the transmitter. Good news is the price, they cut the price in half for the transmitter so that for the same price, you still get 6 months at least of transmitter life. And personally, I found the transmitter signal to be a little bit less wide of a range than it was with the G4. The radio signal seemed to go 30 feet plus very easily. with this, it really seems to be limited to about 20 feet or so. You get beyond that, and it just starts losing the signal. But other than that, I mean, those are kind of minor inconveniences. Everything else about it's really nice.
And in order to download, you had said that you can't scroll back further than 24 hours, but if you want to download like your last few months from the Dexcom, do you do that now directly from the phone, or do you still have to use the Dexcom receiver for that?
No, it's done directly with the phone. There's another app called Clarity, which generates reports off of the data that's stored in the Dexcom G5 app. I just started looking at the Clarity reports today. It was the first time I had patients starting to send them to me. They're different types of reports, and a lot of people think that they're user-friendly for a lay user, someone who's not a healthcare provider who's really analyzing these in detail. But for someone like me and my colleagues, it doesn't allow us to customize quite as well. We can't get as granular with the data as we did on the Studio, or if we download it into Diasend, we can merge it with most of the pump data. You can't do that yet with Clarity. I imagine they'll probably make adjustments at some point, but yeah, the download is, I guess, another little bit of a weakness. It's going to take time for that to become as robust as we really need it to be. Do you download your sensor data at all?
Oh, that's not a loaded question at all, coming from a certified diabetes educator.
I think it's a pretty straightforward question. It's either yes, I do, or no, I don't.
Sometimes.
When's the last time?
A really long time ago. No, the last time I downloaded it, my sensor data was probably just a month ago, so not too bad. And I made some adjustments based on that download. What was interesting, this is something actually that I learned from working with you, Gary, is that it's really possible to feel like I absolutely know that I'm seeing a pattern. Like for the last 15 days in a row, the same thing has happened, and now I need to adjust my basal rate, obviously, based on this. It's really easy to feel very certain about that and then discover that you're wrong when you look at your sensor data, and that somehow in your brain you've come up with this pattern that you think is really, really clear. And when you look at your data, the pattern is either it's something different or it's just kind of spottier than you thought. So anyway, I downloaded my data about a month ago because I felt very certain that I was suddenly seeing a dawn phenomenon effect that I hadn't seen in a long time. Suddenly I was waking up in the 200s and 300s every single morning. I thought, this has now been going on for at least a week and a half. Clearly this is a basal rate adjustment that needs to happen. I downloaded my data, and it was true that my blood sugar had been high in the mornings, but it was bouncing upward out of a low that had happened in the middle of the night each time. So what I thought was the obvious answer to increase my basal rate in the morning was actually not the right answer. I needed to look further back.
The power of seeing the full picture.
It's really true. Really
learn the context of the situation and not just what's happening in that moment in time. That's great. I'm glad you discovered that.
Yeah, it's I think that's probably a mistake that a lot of people make, and because I feel like blood glucose is like this game of Jenga in a way, that like you pull one thing and everything over here changes, or you remove something that seems like, oh, we don't need that, and the whole thing falls on the floor. Yeah. And so it can be so hard sometimes to identify, I'm seeing a problem, but I don't know where it originates or what I need to do to fix it.
Yeah, that's why more people should be working with a good diabetes educator, because they're good at analyzing those kind of details. Physicians tend to not have the time to get into that much detail about things, but a diabetes educator who understands type 1 and all the technology is usually much better about diving in and looking for those kind of cause and effect relationships. One thing I love looking at are patterns by day of the week, and the Dexcom software lets you do that. I mean, you can do it with any program, but you have to hand pick it out. Some of them let you specifically choose days of the week to look at. So I had a guy in here earlier who plays hockey a couple of days a week, and we looked at his blood sugar patterns the day after he plays hockey. So he plays Monday and Friday, so we looked at Tuesday, Saturday. And yep, Tuesday, Saturday night, he's dropping through the night. So we learned, yeah, we need a basal adjustment those days. There's a med student in Michigan I work with, and we looked at her data, and when she works night shifts and has to sleep, between 7 a.m. and 2 p.m., her blood sugars drop while she's sleeping because she's getting her usual daytime basal rates then with a peak in the morning. That's right in the middle of her sleep time, though, so her glucose is dropping. So that's a good way of using the kind of the other basal patterns on a pump. And she's on a tandem pump, so we set up a whole different profile for her with different basal and bolus formulas and that sort of thing. So that's the kind of stuff a good diabetes educator can figure out for patients and those kind of things. There's 9 times out of 10, if you look hard enough, you'll find answers to those sort of patterns. Sometimes you just never find them. The diabetes gods are just out to smite you, and
it's
there's
because
not a darn thing you can do about it.
The wrong color and the weather's weird. And sometimes it's just
your socks don't match, and it just messes things up for you.
It's completely messed up your blood glucose. Hey, I have a question. Since you stay really on top of sort of upcoming improvements to insulin pumps and CGMs and things like that, you're talking about having basically different basal needs on different days depending on what you do on different days. I remember when you and I were working together, you discovered that I tended to run high on weekends, and it's because I eat like crazy on the weekends and not nearly as much during the week. I don't have time to eat during the week, but on the weekends, woo, all kinds of time. So something that I have wanted in a pump feature for ages is the ability to have an automatic, like, this is my weekend basal rate, and and I don't have to like think to turn it on or set it or whatever.
Well, guess what? There is a pump that does that.
Hey, really?
Yeah, but you can't get it anymore. It was the Deltec Cosmo. It was the only pump that could ever do that. You could tell it to run certain basal patterns on certain days of the week.
That's incredible. See, and that was a long time ago that Deltec figured that out. This is the Deltec Cosmo. For folks who are watching and don't know this, I never got to try it, but it is this pump like of lore. Like people used to use it once it was discontinued, hoarded supplies, and I know people who are still using it because it's that amazing.
You should have called it the Frodo pump or something, because it was mystical, It had some very forward-thinking features. It was the first pump with a site change reminder. And you look today, half the pumps on the market still don't have a site change reminder. It's such a basic thing, but it's so important. If your PDM didn't remind you on the 3rd day to change your set, you wouldn't remember. You'd go right, you're a busy woman. You got other things going on.
That's exactly right.
Yeah, the other thing I discovered using my CGM, I do all this experimenting on things. I was overseas doing a program out in Austria, and my blood sugar was climbing really high. It ended up I was having an infusion site problem. So my glucose was spiking up, and I was about to do a talk in a couple of hours, and I didn't want to run really high during that. Because you're standing up on stage and you got to pee your brains out. It's just not a comfortable thing. So I wanted to get my blood sugar down fast. So I got out a syringe and gave myself an injection into a muscle. And then I watched on my sensor screen exactly what happened. So the little box there shows where the bolus or where the shot was given. And you can see how fast it came down. Within 90 minutes, I leveled off. So the intramuscular shots can be a pretty potent tool for fixing high readings quickly.
You and I have talked about this before, because the idea of an intramuscular shot to me is a little bit horrifying. People say like, oh, it kind of stings. I'm kind of scared of needles, and I don't.
Good thing for a diabetic to be scared of needles.
It's terrible.
I don't like IV needles. When I have to give blood and do lab work, I get a little queasy. But this is something that's typically you're giving it into fat, but you can do it in your arm, like your tricep. you're a dancer, you're pretty muscular, so you can do it in the arm, you can do it in the forearm. So what I did is I gave the shot in the forearm, just kind of flex the muscle a little bit, and it started working. It's so much faster than giving it into the fat layer.
Yeah.
As long as you use good, clean technique, there's really not much risk. So I recommend doing that anytime someone is ketotic, because the insulin absorbs so much more predictably. If you give insulin into fat when you're ketotic, it might take forever to work because you're dehydrated at the same time. So if you forget to dose for a meal and you're sky high, do it into the muscle. Or if you're about to do an event, like a sports event, or like in my case, getting up to do a talk and you want to be in a good, healthy range, you can do the muscle shot. It seems to lower the blood sugar the same amount as a normal injection or infusion. It just does it much faster.
So that was kind of my question. I know for a lot of people find that they become more insulin resistant the higher their blood sugar is, and definitely I know that if my blood sugar is over, I don't know, 200 or so, I might need to even double the amount of insulin that I would do in order to actually bring it down. Would that still be exactly the same if using injection? I don't know why I'm stuttering. I should do a blood test. Would that still be the case if I did an IM shot?
Now, with the IM shot, you should be able to assume you're going to come down your usual amount per unit. I'll tell you something funny, though, since you mentioned that. There was a pump that could be programmed to increase your correction doses by a percentage if you were above certain numbers. So let's say you were above 200, it could tack on 10%. Above 300, it tack on an extra 20%.
That's brilliant. Was that Deltec Cosmo?
How'd you guess?
Seriously, the Cosmo could do that?
Yeah.
Can you explain why other pumps have not adopted some of these brilliant features that the Cosmo had?
I think some of it is because of patent protection, but it's been a while, so I'm not sure. I have a feeling they're just, they're not as innovative as those guys were. I mean, there are other things that pump companies have come up with that are really good that Cosmo didn't have. But yeah, I would like to see some of those features in our modern pumps. Another thing that I played with recently was the new insulin that Lilly came out with. It's Humalog that is double the normal concentration. They call it U200. All of the insulin we use now is U100. Standard concentration, 100 units per ml or cubic centimeter. This stuff has 200 units of insulin per ml. So it's basically double the potency. And what I wanted to figure out was whether it could be used in pumps, because a lot of people on pumps don't get enough life out of their reservoirs. They run out of insulin before 2 or 3 days is up because they're just going through a lot of it. So I tested it in the Omnipod, in the Medtronic pump, and in the Tandem pump. And I tested it just on a table just to make sure it would flow properly. And then I wore them to make sure everything worked right. And it worked beautifully. I didn't run into any problems at all. So essentially, if your pump now holds 300 units, putting this insulin in would be like expanding to 600 units that it would hold. However, you have to be really careful about your doses. You have to cut your basal rates in half. You have to cut your boluses in half as well. So your carb ratios have to be doubled. If you're normally on a 1:12 ratio, it's got to be a unit per 24 now. And your correction formulas have to be cut in half as well. So if 1 unit normally drops you 30 points, you'd have to change it to 60. So once those formulas are changed, it's perfectly fine. The only thing you have to worry about then is that if you do manual dosing, the angry bolusing when you're high, for example.
Rage bolus.
You got to remember, you rage bolus, you got to remember that insulin has double potency. So if you'd normally give 3 units to cover a high reading, it's like giving 6. So I have people put a sticker on their pump just as a reminder that there is U200 insulin in there.
Absolutely. I mean, that seems perilous. Mm-hmm. So is there a reason to use U200 other than that issue of if you tend to run your pump dry before the 3 days are up?
It really isn't. It's really just for people who are kind of insulin resistant that might go through more than, say, 80 or 100 units a day. There's a fair number of adolescents that do that. People who are very heavy, overweight might need that. Type 2s on pumps often need that as well. So, it's not FDA cleared for use in pumps, but then again, half the insulins we use were only recently approved for use in pumps. So, yeah, I don't know. Tested it, works great. Didn't see any issues. I don't see why not to use it that way.
Cool. Have you tried any other new gizmos, gadgets, and meds recently that you can tell us about?
Not meds. I'm still using a GLP-1, Victoza specifically, or liraglutide is the generic name. Keeps my appetite nicely controlled. I still have an appetite, but it's not excessive. And I can tell because the days I don't take the injection of liraglutide, I just eat from dawn to dusk. I just can't stop eating. My insulin total for the day is double what it normally is. So using it, I know, keeps my appetite controlled, keeps my weight controlled, and helps with the blood sugars overall. Still have some people using Symlin. I get emails now and then from people trying it and want to know how to use it right. This is an interesting little statistic. People who start using Symlin, what do you think the chances are they'll still be using it in a year?
I have absolutely no idea.
Think about I guess product adherence. What's the adherence rate with Symlin? How long do you, in a year's time?
I'm gonna just spitball it. 50%.
How about 11%?
Oh dear.
It's an effective medication, but it's tricky. It's a bit complex to figure out the dosing, the timing, etc., and deal with the side effects. So they have a very low rate of adherence and long-term use of the drugs. I get a lot of emails from people asking about how to use it right. I tried the SGLT2 inhibitor, the oral medication that causes you to urinate your sugar away more often. I struggled a bit with that. They've since learned that if you're not careful about maintaining good hydration and good dietary habits, you could actually wind up in ketoacidosis using those, even with normal blood sugar levels. So they're not being utilized that widely with type 1s anymore. But it's one of many weight loss aids. There's a number of products, medications out there that can aid people with diabetes who are trying to get their weight off. With the holidays coming up now, Halloween is my biggest challenge. Forget Thanksgiving and Hanukkah and Christmas. Halloween, man, that's a tough one.
Because you love candy corn like crazy?
I love this stuff. We got bowls of chocolate and candy for, it's not just, it's the kids' candy, but that's what I call that's my kids' living tax if they want to live at home. They got to come up with some candy now and then.
So let's talk about holiday food and eating and how to manage all of that with diabetes.
All right. Well, Halloween is one of those do as I say, not as I do situations because I'm not.
I hear
that. The other holidays, it's manageable. I think a really important thing is to maintain your workout plan. A lot of people kind of cut back on their exercise during the holiday season, possibly because it gets dark earlier or the weather's not as good or they're just busier with other things. But nothing as important as maintaining those workouts. Because you can start to put weight on very easily. And when you go as little as 2 days without exercising, your insulin sensitivity starts to plummet and your blood sugars are going to go up.
Absolutely. I really see that in myself for sure. For exercise recently, I've been swimming in the mornings, and now that it's staying darker later, when my alarm goes off in the morning, it still appears to be the middle of the night, and I find it incredibly difficult to believe that I should get out of bed. And frequently, I don't get out of bed.
Mhm.
But what I'm trying to do, this has been my strategy that I'm trying, is I'm trying to develop a love of seeing the sunrise as I drive to the pool.
Hmm.
And it does look nice that one time that I managed it.
Nice.
It was beautiful. But
Yeah.
that's what I'm working on, trying to do to convince myself that I need to get out of bed and go to the pool now.
So do you face the bay when you're driving?
Yes.
That would be a beautiful scene. Trouble is, you're going to have to do it a little earlier every day until
That isn't going to happen.
Yeah, I found that the best way to deal with those dark mornings is to wake up to some really positive, loud, upbeat music.
Does your family love that?
Yeah, they're really into that. Now, actually, I'm one of the late risers in the family. I work out in the evenings. I'm a night person, so the holidays, maintaining the workouts is important. I also think it's okay to indulge on special occasions, as long as you recognize that it's a special occasion and it shouldn't be a routine everyday kind of thing.
The special occasion doesn't bleed into the entire week.
Holiday season. Yeah.
Right. A season of chocolate and pie. And now I have a question. So I have a Halloween question for you. If we sort of map out a really, I think, pretty common scenario for people around Halloween, right? So I've got a bucket of candy by my front door. Of course, I got candy that I really like, because that's what everybody.
Where?
No, I'm kidding. It's
it's a hypothetical thing.
It's
Darn,
very
but you really have.
hypothetical. I haven't prepared for Halloween yet. And I'm going to, sail by a few times a night and grab out a candy bar. Or, I mean, if they're the little tiny ones, I'll grab out a few candy bars. What's my best game plan to try and manage my blood sugar through this sort of continuous influx of sugar that I normally wouldn't have?
It's not going to happen. I mean, you're not going to be able to manage blood sugar with that kind of grazing activity. But I think if you limit it to one night, it's okay. Grazing just doesn't work. It doesn't matter if it's Halloween or Easter or Tuesday, May 8th. It doesn't matter. You graze, your blood sugars are just going to be chronically elevated. But it's okay. Treat yourself one night. Have the little Nestle miniatures, Hershey miniatures, whatever you're going to have. Bolus for each one if you can. Just don't expect your blood sugars to be ideal. I think if you get back on track the next day and don't let it, like you said, Emily, don't let it bleed over into the rest of the season, it's fine.
Do you think that in terms, I know you're not a psychologist, but in terms of just sort of human psychology around food, do you think that it's preferable to sort of, as you say, accept like, hey, tonight I'm going to accept that my blood sugar is going to be chronically high tonight, and I'm going to let myself eat my candy bars, and I'm not going to feel bad about it. It's going to be what it's going to be. And I'm not going to try to apply a lot of willpower. But then starting tomorrow night, I stay away from the candy bars. Do you think that works better than saying, I'm going to try to just eat 5 little candy bars every night for the next week?
Well, if you start putting restrictions and limitations on things forever, you're almost doomed to fail. So if I said to you, Emily, those little pink and yellow peeps that come out around Easter time that you love so much, well, pretend you love them. If I told you you just can never eat those, you're diabetic, you can't eat pink and yellow peeps.
Well, that,
give me something you like.
You want them.
You're a chocolate person.
Yeah.
Like Dove chocolate?
I like any kind of chocolate. I could find a piece of chocolate in my shoe and I would eat it.
All right. Well, let's say you had a whole shoe full of chocolate, Emily. I mean, if I told you could never eat shoe chocolate again, you would crave it. I mean, it's all you would think about.
I would be so obsessed with shoe chocolate.
I'm not a psychologist, but I know that much, that if you tell someone they can't have or do something, it's all they're going to want to do. So if you're a little bit, flexible and allow yourself to enjoy once in a while, doesn't become an obsession. You don't develop eating disorders that way.
Awesome. Okay, so we allow ourselves an occasional splurge in the holidays.
You know, I used to go low, and I would go trick-or-treating with my kids. Because just walking around carrying stuff and socializing at every door, I'd find my blood sugar would drop. I actually have to cut my basal back when I go trick-or-treating now. And I should have worn my costume today.
Why did you just eat some of your kids' candy? This boggles my mind.
That's the trouble with eating while you're being physically active, is that food just sits in your stomach until the activity's over. So you can eat and eat and eat, and it's going to take a long time to come back up. Plus, the kind of stuff you get, the chocolates don't raise it very quickly. I would use candy corn's another story. You can use that to raise blood sugar pretty fast. It's made with honey, so that'll work pretty quickly. Now, there's a bunch of candies that work as well as glucose tablets for raising blood sugar. Can you name any of them?
What?
Name a candy that works as fast as glucose tablets for raising blood sugar.
What are those things that are actually a lot like glucose tablets? I'm blanking. Sorry, I didn't hear your question the first time because there was a loud motorcycle outside my window. Those sweet tarts, that's what I'm thinking of. Sweet tarts?
That's one. Another one are Smarties.
Yeah, Smarties.
And Nerds and Runts.
I forgot those even existed.
And Pixie Sticks.
Oh, yeah, that would do it.
Yep. And Spree. Got a whole bunch of them. Bottle caps. It's another one. These candies are made with dextrose. So if you look on a label and it says dextrose as the first ingredient, great treatment for hypoglycemia.
Well, that's really good to know. For those of us who are tired of glucose tablets, I just might switch to something new.
Yeah, but they do taste better than the glucose tablets, so just can't allow yourself to be too tempted when you're not actually low. I
need to not intentionally on purpose over bolus for something so that I'll need to treat.
Yeah, we would never advise doing something like that.
No, that's for sure. I would never advise doing it.
Yeah, that's one of those little psychological.
I don't do it myself. So what about other kinds of holiday eating, right? We have, for Halloween, it's typically either super fast, hard candy type stuff like that, or chocolatey type, slower, longer burn stuff. How about, we're coming up on Thanksgiving as well, and just sort of general party season with things that are long sit-down meals, super high carb and super high fat and super high protein, probably really high in absolutely everything except fiber.
Probably. Well, think about some of the characteristics you described. We're talking about large meals, large quantities, long drawn-out meals, and a lot of fat. And all three of those will result in a very slow, prolonged blood sugar rise. They're not going to cause the dramatic rise like when you sit down to have a sandwich for lunch. These are going to cause the long, drawn-out blood sugar rise. So we have to be careful about the timing of our insulin for those kind of meals. Those big, slow, long meals, we have to slow down the delivery of the insulin. So people on pumps can use their combo or square dual type boluses, the extended bolus. And people on injections can either delay their shot, give it 30, 60 minutes after eating, or break it down into a few parts. Give part of your meal dose at the meal time, give part of it a couple of hours later. And it'll do a better job timing-wise of matching the absorption of the food and the blood sugar impact that comes from them. The other thing to think about is if you are having a high-fat meal, you might see more of a blood sugar rise than you'll get just from the carbohydrates. So when there's a lot of fat in a meal, it causes the level of triglycerides in the bloodstream to go up. And when triglycerides are high, the liver starts to dump out more sugar than usual. So we get an increase in blood sugar from that. That's on top of what the carbs do. So those on pumps, we usually recommend a basal increase on top of the bolus.
Is there a particular recommended percentage basal increase or a way to calculate it?
You know, with my clients, I usually recommend going up by about 50% for the next 8 to 10 hours. And they would start that not at the meal, but maybe an hour later. That's a good time to kick it in.
And how about do you have any guidelines for figuring out bolusing for those kinds of long, prolonged meals where usually, I think commonly, or at least this is my experience, I figure I'm going to sort of eyeball what's on the table and what I think I'm going to eat, and I try to go, heavy on the green beans and light on the stuffing or corn, whatever the carby options are. And then, so I fill up my plate and I follow that plan. And then after that, I just start sort of randomly shoving things in my face for the next hour and a half, and then pie comes out. Yeah. And so it's, I start out with the best intentions and a bit of a plan, and then it's sort of all gets thrown up in the air. And I'm hoping I'm not the only person who does this. What on earth should I do?
One approach would be to go into it with a little bit, not a complete game plan, because you never know what's going to taste really good and what's going to come out. And
exactly.
Yeah, but if you go into it with a minor game plan of saying, all right, I'm going to eat 150 grams of carb by the end of this meal. 150 grams. So it's an indulgent meal, so go for it, and then just try to do that by the end of the night. But deliver that bolus gradually over time so that it's not going to kick in prematurely. If you happen to go over your allotted amount, let's say the pie is just to die for, and you want to have a second and it's going to put you over your 150 grams, any pump will allow you to bolus on top of an extended bolus, so you'll be able to do that. So that's a strategy you could certainly try.
Mm-hmm. Nice. How about estimating estimating insulin needs for some of the common desserts that we have during the holidays, like pumpkin pie or pecan pie, which I've never lived through a slice of pecan pie.
You got your fist with you, Emily?
No, I left that at home. Yeah, I have that.
Let me see your fist. Okay, so a woman's fist is usually about 1 cup.
Wait, I think my right hand is slightly larger. I want to use that.
Get out of here. Most men's fists are a little more than a cup. I mean, if it's a big guy, your fist could be a lot bigger than that. But an adult woman's fist is about a cup usually. You can estimate your carb portions based on the size of what you're eating. Pies, cakes, muffins, things like that are usually about 50 grams a fist. It's a good ballpark number to work with. So, and you got to think volume and try to shape your fist to the size of the shape of the food. So if you're having a piece, if you got a piece of, that's pretty good. You got a piece of pie that's the size of your fist, it's going to be pretty close to 50.
The size and shape of my pie-shaped hand.
Yeah, you can do shadow puppets and stuff. It's just a good way to estimate. A cookie the size of your palm is usually about 20. Potato products that are the size of a fist, about a cup, is usually about 30 grams. The same thing, rolls are usually about 25 grams for a fist-size portion. So those kind of estimation tools I find are really useful. Is the size of, you tell someone having a slice of pie, what does that mean? Is it a slice or a slice? It could be huge.
When I was a kid with diabetes, the rule of thumb that my parents got for me for use at birthday parties and things was that I could have a cubic inch of birthday cake, which is like,
that's the size of
a cubic inch.
Couple of dice.
Exactly. It's the size of it is one bite. Even when you're a kid, that's one bite. Yeah. I like that you're using a measure that's a little bit more reasonable and bigger. I like that.
Now,
More
if it's
pie.
the size of your head, no. Give me a head of cake.
So how about things like, for folks who are low carbers, of which we have a lot in our community, what about things like an actual low carb holiday meal that's going to have probably a ton of protein and fat, probably a lot of meat, maybe a lot of butter, heavy stuff that sticks around for a long time. We know that even if you don't eat carbohydrate, you still see a rise in blood sugar as a result of meals that are really high in protein and fat. How do you ballpark insulin for those kinds of things?
Well, what we usually find is if you're not eating carbs in a meal, or it's a really small amount, that a considerable amount of the protein will eventually convert to glucose. And there we have to start thinking about protein counting and then bolusing for about half the protein grams. So an average piece of meat might have maybe 8 grams of protein per ounce. So if you're having a piece of meat this size, it's not that big, like 4 ounces, that could have 25, 30 grams of protein. You got 30 grams of protein, you need a bolus for about 15 grams of those. That usually works out about right. The fat is dealt with the same way it is if you were having carbs. Fat's going to cause that triglyceride rise and insulin resistance, so we raise the basal for the fat. And by the way, for people on injections, I don't exclude people on shots. If you're on injections and you're eating a high-fat meal, you're going to need a little bit of extra basal insulin through the night. And you can accomplish that with a little bit of NPH insulin. That's the older, kind of intermediate acting type of insulin. It works pretty well for covering the effects of fat because its peak is kind of spread out, happens about 4 to 8 hours after it's injected. It's usually right around the time the fat is affecting the blood sugars.
Nice. Something that
I don't want you to forget, I'm Mr. Mom this week. I got to pick one of my kids up at soccer. I got to leave in 10 minutes exactly. So
we have exactly 10 minutes. We have 10 minutes, everybody. Okay. I was just about to ask one thing that we haven't talked about that is a common holiday food for a lot of people. We haven't talked about any of the soups that a lot of people have for Thanksgiving. They tend to be pretty heavy, creamy, corny, creamy, squashy soups. Do you have any rules of thumb for bolusing for that sort of thing?
I mean, if they're high-fat soups, treat it like it was stuffing or mashed potatoes. The carb count you can usually get out of any book or app. The soups don't tend to vary all that much based on with the carb count, but the fat, like you said, can really add up. If you got a cheesy or a cream-based soup, it could be a lot of fat in that, as much as in a fast food meal. So you will need to get the extra basal insulin for dealing with the effects of that happen later on. I'm more of a matzo ball soup guy, so I've learned to estimate carbs in matzo balls. You got your dense matzo balls, then you got your loose, fluffy matzo balls. So.
Sorry, I'm having unmuting problems. There was apparently a family feud in my family, my grandparents' generation, about whether the loose, fluffy matzo balls or the hard, dense matzo balls are better. And since we're discussing it and we haven't talked about any specific Hanukkah-related foods, how about carb counting matzo balls? Do you have to account for whether they're dense or fluffy? Do the dense ones have more carbs?
Yeah, you never really can tell until you put your spoon in one. If your spoon sinks right through it, you got your fluffy matzo ball. Yeah, and those, one that's about the size of an egg would only be about maybe 15 grams of carb. But if you put your spoon on it and it doesn't break the surface, it's a heavy leaded matzo ball. I mean, that could be more like 25 grams for a single one. There's other stuff on Hanukkah too, potato latkes, or it's like fried potatoes. Those can be a lot of carb also. And I would use that rule of thumb like with the cookie. If it's the size of your palm, it's going to be about 20 grams of carb. And if it's the size of a full hand, it's going to be more like 30 to 40 grams of carb. It's a thing. You take potato pancakes, you dip them in applesauce. It's good eating.
It sure is good eating. All right, so because the chat room has been down, I haven't been able to take questions from our audience, and I'm really sorry about that, guys. We will look into what's going on with our chat room. But Gary, I want to let you go so that you can go pick up your kid at soccer practice. Is that what you just said?
My seventh. This is my little one, Milani. She just started playing soccer, and her 7th grade team has a game today, and I want to go catch the end and be able to drive her home.
That's fantastic. Go do that. And thank you for being here with us today. I learned a lot about bolusing for holiday stuff. And I think my biggest take-home message from this talk is I'm going to just let myself have Halloween candy on that day and then get rid of the candy. That'll be my day for a Halloween splurge. And I'm not going to beat myself up about it. I'm not going to try to limit myself so that then I still feel deprived the next day and I want to go revisit my Halloween bucket. I'm going to have my Halloween and then stop having Halloween once the day is done.
I think that's a fantastic plan, Emily.
Awesome.
And again, mention if people have questions, they can email me directly if they want to. And if anyone needs help with their diabetes, they can give my office a call, and we do appointments worldwide with folks. So.
Nice. What's your email address and what's the name of your company again?
The company is Integrated Diabetes Services, and the website is integrateddiabetes.com. The phone number is 877-339-2664. And my email is gary@integrateddiabetes.com.
Fantastic. Thanks so much, Gary. I'll talk to you in a couple of months.
Can't wait. See you later.